Welcome back. Now, when I've looked at past programmes, a lot of the sessions were really diabetologists and their researchers talking to each other, and there wasn't so much on complications from other disciplines. But actually that's changed quite considerably, and we've got sessions on cardiovascular disease and on other complications, and also one on chronic kidney disease. So I'm delighted to welcome two people from one of those sessions. And first of all, we have Katherine Tuttle. Katherine's from Providence Health at the University of Washington, and you are a clinician and a nephrologist.
Yes, I am.
And we also have Hiddo Heerspink from the University of Groningen, and you're a clinical pharmacologist who's somehow snuck into nephrology.
Yes, indeed.
So tell me about your presentation.
Well, in our presentation, we are really focused specifically on people with type 1 diabetes and chronic kidney disease, because this has been a relatively understudied population. Most of the studies for the new kidney disease therapies have been conducted in people with type 2 diabetes. And the last time we had a new therapy approved for kidney disease and type 1 diabetes was over 30 years ago.
Wow.
And that was the old captopril renal study of the ACE inhibitor. And we've had very few studies since then, and the ones that have been done haven't delivered any new therapies. But this is still an important population and a large unmet need for them.
First of all, I'm extremely grateful that we had the opportunity to present the data at this symposium, because as you said, EASD traditionally had focused on glycemic controls and less so on complications, and we see that there's more and more attention on the complications of diabetes. And as Kathy just said, initially we focused a lot on type 2 diabetes and we forgot a little bit the type 1 diabetes. But type 1 diabetes and chronic kidney disease is associated with a very high risk of complications, kidney cardiovascular complications, with very few proven effective therapies for these patients. And that's why we presented an overview of ongoing clinical trials with new therapies for these patients, because they deserve new medications just like the other type 2 diabetic patients.
And we've seen some spectacular success in cardioprotection with some of the new glycemic control drugs. Are we seeing the same with kidney disease?
Well, yes, in type 2 diabetes, in fact, the breakthroughs we have had, particularly with drugs like SGLT2 inhibitors and finerenone, have really given us unprecedented benefits. And on true clinical endpoints, progression to kidney failure and even death, particularly death due to cardiovascular disease. But so far the studies have been limited to people with type 2 diabetes, with the type 1 population sort of left out of the trials. The other thing that we talked about too is the epidemiology of kidney disease and type 1 diabetes, because other than the DCCT edict study, which was only 1,441 patients who entered a study in the 1980s, we've had very little epidemiologic data to really define the prevalence and the stages and severity of kidney disease in this group of patients. So we also reviewed some data that's contemporary, showing us how common it is, and particularly in people who are older adults with type 1 diabetes. And now with the many successes we've had with treating type 1 diabetes, many people do live into older age. And in that group particularly, we see very high rates of kidney disease as well as cardiovascular disease.
So we've got two kind of presentations, although we're gradually realizing that there are many presentations of type 1, but you know, the childhood or adolescent onset and then this adult onset. So certainly in the adolescent onset, you've had years and years and years of being exposed to fluctuating glucose levels.
Well, even with the improvements in treatment of type 1 diabetes that have led to greater longevity, I think what our data soberingly show is that we really haven't prevented complications. We've just done a time frame shift. So particularly if you look at people over the age of 60 with type 1 diabetes, more than half have chronic kidney disease. And it's not just albuminuria in early stage. We showed that 25% have advanced stages of CKD, which really helps make the call that we need earlier efforts at screening, identification, and intervention.
And you could argue and ask yourself the question, why is it so difficult to develop new therapies for these patients with type 1 diabetes and chronic kidney disease? Yeah. Well, I thought about it, and if you look back, the traditional clinical studies have been focused on dialysis to demonstrate if a drug is going to be effective. But on the other hand, dialysis is a late manifestation of chronic kidney disease, and to demonstrate a treatment effect on dialysis, you need a very large study, which is difficult in type 1 diabetes. Type 2 diabetes is a little easier because you have so many patients, it's easier to recruit these patients. The regulatory agencies like the FDA or the European Medicine Agency acknowledge this, and they have started to change and to accept surrogate endpoints. Surrogate endpoints can substitute a clinical endpoint if they are well validated.
So what kind of endpoints are we talking about?
Yeah, and when I was talking about surrogate endpoints, we can look at the rate of progression of kidney disease, rate of GFR decline, or albuminuria. And what we see indeed is that there are now more and more studies that do not only look at dialysis, but also look at the rate of progression of GFR decline, albuminuria, as valid substitutes for these clinical endpoints, which facilitate clinical trial conduct, which makes it easier to do more clinical trials and to translate the evidence that we have in type 2 diabetes to type 1 diabetes.
And is it a question of just putting the same medicines that you use in type 2 into type 1, or are there subtle things that you need to do differently in type 1?
We always have to be careful. We cannot just translate SGLT2 inhibitors from type 2 to type 1 diabetes. It's a nice example because we know that in type 1 diabetes, SGLT2 inhibitors may increase the risk of ketoacidosis. But for other drugs that do not directly interfere in the glycemic process, I believe that we can translate and apply drugs that have been proven effective in type 2 diabetes for patients with type 1 diabetes. And a nice example is the non-steroidal mineralocorticoid receptor antagonist finerenone that blocks aldosterone in the kidney, reduces the inflammation, the fibrosis in the kidney, and thereby protects against further kidney damage.
So what are the big trials that we can look forward to?
The outcome study, a big trial that now is going to start in type 1 diabetes, is the FIND-1 clinical trial. It's a clinical trial with finerenone using albuminuria as the surrogate endpoint, which I just explained. There's another very nice clinical trial starting next year, STENO-1 in Denmark and Greenland. It's a big clinical trial that uses different medications, again finerenone, but also sotagliflozin, semaglutide, and provides these medications according to the risk profile of the patient, which goes into stratified or personalized medicine.
Now that's something, Katherine, that we're hearing more and more of, is stratification. So it's no longer the type 1 patient, it is the type 1 patient in this particular basket or that particular basket.
Exactly. And I will add that in the United States, the Juvenile Diabetes Research Foundation has also issued several grants that will conduct studies in the U.S. A semaglutide in people with type 1 diabetes with CKD study, and also an SGLT2 inhibitor study in people with type 1 diabetes and CKD. So it's nice to see the international community coming together around doing these trials, and we need to have different groups doing them. One, so we have more diverse populations, but two, so we can compare results between the trials and learn even more, because they'll be a little bit different. And also, too, when there's more than one trial, it helps, if you will, validate the results, especially when we're using surrogate endpoints.
Yeah.
So I have to ask this of a nephrologist. We've got some drugs now that are really promising, astonishing results in terms of reducing chronic kidney disease. does that mean that we should be much, much more rigorous about screening for kidney
Yes.
disease? I mean, albuminuria, for instance.
Absolutely.
And the healthy population, or those people when they're diagnosed with?
Well, at this point, the recommendations from clinical practice guidelines are to treat high-risk or screen high-risk groups, such as people with diabetes. That said, in the United States, the U.S. Preventive Health Services Task Force is actually reevaluating the recommendations for screening. And one of the reasons is that kidney disease is so common even in people without diabetes. So, for example, people with hypertension, people with a family history, or just having cardiovascular disease. So they're really assessing the evidence about whether the screening should be broader. And one of the reasons is we now have these super powerful tools where we can do something about it. So if, for example, even in the non-diabetes population, SGLT2 inhibitors prevent progression, there's more rationale to screen them before we had these therapies. So I don't know what's going on in Europe, but this is actually a huge initiative in the United States to reassess screening protocols and define which population should be included. I think it will go broader than diabetes, but for example, there's really not a guideline that suggests screening in hypertensive patients. I hope for sure they say that. But the real question will be how far the evidence allows to go with recommendations for screening. But in the Netherlands, you've been involved. So I was going to say, you may have some thoughts about your PREVENT study and all.
In the Netherlands, we go one step even further and now start this year a national screening program for CKD in more than 300,000 adults older than 50 years. Because we know that if you identify chronic kidney disease early on, chronic kidney disease often associates with other cardiovascular risk factors, hypertension, diabetes, obesity. So by screening for chronic kidney disease, we not only detect patients at risk for kidney disease progression, but also the patients in whom there's diabetes or hypertension, which the patients don't know. So this is the approach that we're now going to take in the Netherlands. Screen the general population, just like we do screening programs for breast cancer or colon cancer, because the mortality rates are equal.
That will be a fascinating set of outcomes.
Well, and I think you hit on something really important, mortality. So one of the reasons that the classic kidney disease trials have had so few event rates is not only the time to get to kidney failure, but ignoring the enormous mortality rate on the road to kidney failure. So many people with chronic kidney disease, in fact, most will die and not make it to dialysis. As nephrologists, we should say, congratulations, you survived. And the competing risks are related to having the kidney disease. It's not like they're randomly getting another condition. For example, the kidney disease is the major risk enhancer for cardiovascular death. And 10 years ago, I think we published a study out of NHANES that showed people with diabetes, and it was a general population, so probably mostly type 2, but some with type 1 in there, that having albuminuria further enhances risk of cardiovascular or all-cause mortality 5-fold, low GFR 12-fold, and if you had both, 30-fold. So even if you want to focus on cardiovascular risk, you should screen for kidney disease. But the point is, kidney disease is the major risk-enhancing factor for death. So we need to consider the competing risk of death as a complication of CKD, and the old trials had blinders on to that issue.
And to just bring it back full circle again, the drugs that are being presented here are just astonishing in their effect.
Well, and they hit the full arc: death, cardiovascular, kidney. So, we really do have this mantra now: save kidneys, hearts, and lives.
And maybe
it's a great slogan.
And maybe that's the abbreviation: CKD, cardio, kidney, diabetes. The drug that works in all these areas, and that's what we have to now implement in type 1 diabetes.
Fantastic stuff. So it really is a new era, and it requires not just the drug, we've got the drugs now, but the real hard work on accessibility, on the actual, practicalities of implementation.
Detection, intervention.
Yeah.
Because even in the type 2 population, these powerful tools are markedly underutilized, and people don't benefit from treatments they don't receive.
Well said. Well, thank you both very much for joining us. And it's great to have nephrologists, well, a kind of nephrologist.
A nepropharmacologist.
A nepropharmacologist.
Well
Thank you so much. Well, we'll be back soon with yet more from EASD TV. Bye for now.